Ahora vamos a poder compartir el simposio del doctor Kumar, un simposio que gentilmente nos comparte la empresa Varian sobre radioterapia adaptativa con inteligencia artificial.
Hi everyone, I'm Kiran Kumar. I'm from UT Southwestern in Dallas, Texas. Assistant professor here, and I do pediatrics and lymphoma. I also help run a residency program. I'm honored to be able to speak today to everyone. The title of my talk is Efficient Adaptive Radiotherapy with Artificial Intelligence and Human Ingenuity. Here are my disclosures. Okay, so here is an outline of the talk over the next half hour or 40 minutes. So first, I just want to introduce you to our department to show you kind of the technology we have, and then focus on ethos and how we use ethos and adaptive radiotherapy to treat patients. And so the first part of that will really be talking about the implementation of ethos, how the timeline, how we got it implemented and got it going, what we've learned from our initial experience from it, and how the AI and machine-driven process works to help with adaptive radiotherapy. And then the second part will be going over our clinical experience. So how do we choose patients for adaptive radiotherapy? And I'll show you some cases, and I'll talk to you about this new concept called pulsar that you may or may not have heard of, and talk about that and regular SBRT or SABR as uses of adaptive radiotherapy. And then finally, at the end of the talk, I'll talk about our plans moving forward. So how do we improve the quality of our adaptive radiotherapy at Ethos, as well as some logistical things that we hope to improve as time goes on. So here's kind of the learning objectives. So to understand the treatment process for adaptive radiotherapy on Ethos, to recognize key clinical workflow considerations to successfully implement Ethos in your clinic, to identify patients who may benefit from adaptive radiotherapy on Ethos, and then to consider novel near future applications of Ethos like pulsar that we mentioned. So here's an overview of our department. So at UT Southwestern in Dallas, we're very lucky. We have a lot of technology. So we had this building that we call EROC on the left, and this was our original building. It's kind of our own standalone radiation center with 4 true beams, 2 electroversas, a CyberKnife, gamma pod, gamma knife. And then last summer, we opened an entire building that we call AROC, which is our Adaptive Radiation Oncology Center. And this whole building is dedicated to adaptive radiotherapy. And we have Ethos, but we also have Halcyon, we have MR Linux, PET Linux, and MR Sim, and a CT Sim. And so, you know, we have a lot of technology, and I'll talk a little bit about how we, why and how we use Ethos specifically for a lot of cases. And so for more of a departmental overview, we break our department into disease-oriented teams, so breast or prostate, so forth. There's 22 physicians, medical physicians. There's 22 faculty physicians, 14 residents, 24 faculty physicists, and 12 physics residents, 11 dosimetrists, and 14 therapists. So we have quite a large department. Really what we've enjoyed doing and using and what we've used the most by far since opening the Adaptive Radiation Center is the Ethos. And as most of you may or may not be aware, you know, Ethos is it's a comprehensive treatment suite, right, that allows for both adaptive and non-adaptive IGRT treatment. And it has treatment planning, treatment delivery, treatment monitoring all in one. And so I'll talk about that and how we've kind of used that as part of our workflow and to integrate with the other machines we have. So this is the first kind of thing I want to talk about, which is the timeline. So our Ethos Go Live timeline started in April last year, where we started with some machine TPS matching, and then the Acuros XB model commissioning and credentialing happened in May. And then before we actually went live on June 2nd, we actually had this team dry run, which I'll spend a little time talking about it. It was a week before the go live day, and we had these hands-on Ethos adaptive radiotherapy experiences for all of our radiation oncology faculties, as well as the physicists. And so this was done in early May. It was a full day. There was about 4 to 6 faculty per session, and this was extremely helpful. So the reason that I've included these slides is because without this, I think most of us would not have known much about ethos and how to use it. And this, one-day session really helped a lot. And so you can see here that it was the first session was kind of Varian led, and then we had a second UT Southwestern led session that was for 1 hour, where everyone actually did a simulation of doing an ethos treatment and adapting. And so this is the plan we use: the prostate, getting 40 grade 5 fractions, with the clinical pre-plan being generated, reviewed, and then the actual day and the adaptation process. So this is something, if any of you are thinking about getting an ethos or how you would implement it, I would recommend doing these practice sessions. So I want to switch gears and talk a little bit about the workflow that we've implemented at UT Southwestern. So, we have not all, but mostly Varian products. And so we're very familiar using Eclipse for contouring. And that's what a lot of our physicians have kind of used to and are familiar with. And so we've kind of kept that as our workflow for even ethos. And so in our current workflow, we actually import the scans into ARIA Eclipse, and the physician will use Eclipse for contouring. And so just like normal, we'll contour GTV or CTV. We'll do margins for PTV. We'll make sure any supporting images are fused. So if there's a PET CT or an MRI, that's fused. And then after that, we will send it to our planners, and the planners will actually do the planning in ethos. And so as physicians on the MD side, we'll tell them, hey, each day we're going to adapt the GTV, or we're going to adapt the CTV, and the PTV is a 5mm uniform expansion, or if it's not uniform, we'll tell them exactly what dimensions. And so, the planners then, and right now it's physics who's been doing most of our ethos planning, they'll choose a template based on the anatomy site. Influencer contours will guide target deformation, so that's important. And then we'll kind of set up our recipe for online adaptive radiation optimization. After a plan is done, we actually send it back to Eclipse, and we will review this in Eclipse. And then if we like the plan, everything will go forward with approving. And this is all the pre-plan before we actually bring the patient in and start the adaptive radiation therapy. So here's an example that I just wanted to show you. So this is a lung saber case that we're doing on the ethos, right? So you have the GTV, and then everything else is auto contoured. So the PTV is an auto expansion. There's rings to help with planning and trying to keep 50% dose within this 2-centimeter ring. And we give all our priorities, and you can see all of that listed here. And most important, very important. So all of that's done ahead of time, right? And then when you actually get to the day of adaptation, the machine uses the same priorities to do the plan that's created the same day. And what's been exciting to see that we've actually, been studying and looking at is that ethos can create plans of the same quality as Eclipse or TrueBeam. And this was very important for us to know because we didn't want to have any sort of deterioration, and we've been very happy with these results. At our institution, peer review of planning strategy and plan quality for every ARTs, the adaptive radiotherapy, for every ART case prior to physician's plan review occurs. And this helps ensure that the optimization approach is robust against any uncertainties in anatomy change. It also allows us to evaluate the plan quality to make sure it's reproducible with quick online adaptive planning. So this is something that we also would recommend. And now I think this is where I want to spend some time because I think this is really important. A lot of people will ask, well, what actually goes on the day of in terms of the adaptation? So here is an overview of the on-couch ART process on ethos, and specifically how AI and machine learning helps drive this process and make this as efficient and pain-free as possible. So the first step is doing a cone beam CT, like you normally would for IGRT. The image quality is extremely important. I'll talk about that more at the end of this. talk. So sometimes we'll give contrast, or we'll do breath hold to minimize motion that can help with image quality. We want to make sure that the scan ISO is close to the treatment ISO to ensure that there's, and because there's not allowed to have a couch shift between the pre-plan and the ART plan, or minimal at least. Then after the cone beam CT is obtained, the physician will review it, make sure that it looks adequate, make sure it's has everything you need in terms of what all was included in the scan, and then the influencers are contoured. So before we go into the target OAR contour, we will check the influencer contours and fix them as needed. And these are structures that are the closest proximity to the target and have the biggest impact on their shape and position. So these are really important, because the better you do in choosing appropriate influencers, the better you are going to get in terms of the auto contouring. So then the AI machine-driven process works better if these are accurate. And so we will review these and revise as needed. And then after we've adjusted the influencers, then this is where the magic happens. And this is something that is working really well, but it's still not perfect. And we're trying to get improved as time goes on. So after you adjust the influencers, the computer will auto contour everything. So it has today's cone beam CT, it'll auto contour the normals, it'll auto contour the target. And often it's almost perfect and you don't have to do much. And sometimes for one reason or another, things get messed up and you do have to edit the contours. And so our job as the physicians is to go and look at the normals and look at the targets and adjust them as needed. And I'll show you some timing statistics so you know how long this takes. Once the contours look good, then the computer will replan. And this process works pretty quick. Obviously, it depends on the complexity of the plan. And then you're given two options. You're given a scheduled plan and an adapted plan. So this screen you can see this is the scheduled plan and this is the adapted plan. And especially when there's changes in anatomy, changes in tumor, or changes in structures relative to other structures, you'll see a pretty dramatic difference. If there's no difference, you can just treat with the scheduled plan, and that's basically like doing IGRT. But if there is a difference, like in this case, then the adaptive plan looks much better, a lot less dose to the kidney that's nearby, for example. Now we have the ability to QA the adaptive plan and treat right away. And so that's the final step. And this whole process can be done fairly quickly. Obviously, it's not as fast as IGRT, but you'll see, I'll show you some of the timing statistics, but the MD being there is on average only about 15 minutes. So it takes time, but it's not a lot of time. And this whole process can happen much quicker than obviously it would be to re-CT sim and replan someone. And so this is something I just wanted to briefly mention. So this is looking at ethos contour quality, so looking at the AI influencer in different parts of the body to see what works well, what doesn't. And influencers are auto contoured well, normals are auto contoured well. It seems like the GTV is the one, or the target is the one that requires the most time and attention from MDs. Which makes sense because those are things that change, and those are things that we want to be extra careful or that are accurate. All right, so that's kind of the practical portion of the talk. Now I want to get to kind of what's more exciting to me, which is the clinical cases and talking about how we choose patients, why we even do this, why do adaptive radiotherapy. So I think I like to start broadly with thinking about who benefits from adaptive radiotherapy. And we've really broken this into two groups when we think about it. One group is if patients may benefit from anatomy adaptation. And so that would be because the target or a nearby OAR moves from day to day or may not always be in the same place. And having those completely accurate is essential. And so we see this a lot in GYN, GU, or GI tumors. There's organ motion, bladder filling can change, in GU, right? If the bladder is full or is empty, that makes a big difference. If you're doing prostate SBRT, same with if you have rectal gas or not. Normally you'd have to, have certain protocols for bladder emptying or filling and trying to release rectal gas. The nice thing about doing adaptations is that whatever it looks like that day, you can adapt to that change and make a new plan and treat without having to get everything else like it was at SIM. In head and neck cancer, patients lose weight, anatomy changes, or in general, if there's any target that's abutting a critical structure or prior radiation field, like a lung target adjacent to brachial plexus, it could be really important to know where that normal critical structure is on a day-to-day basis to avoid it. And so this is one use of adaptive radiotherapy. Another group or use of adaptive radiotherapy is response adaptation. So like in radiosensitive tumors, for example, if you have a change in tumor size over time, you can actually change your radiation, shrink your volumes, and treat a smaller volume. And now this will, lead to less toxicity because there's less nearby OARs that are getting radiated. And this is where the concept of pulsar comes in, which I'll talk about in a minute. Broadly speaking, what are the goals of adaptive radiotherapy? Well, one is that it's more accurate, right? We didn't realize before we're doing this, but now that we're doing a lot more of these cone beam CTs and comparing schedule plans to adaptive plans, we realize that if you're just doing IGRT, often it's not nearly as good of a plan as you expect when you actually look at what the anatomy looks like that day. So by being more accurate, of course, that would lead to increased efficacy and decreased toxicity. Other goals of adaptive radiation, which we're studying on protocols and trials, are PTV margin reduction. If you're able to do a cone beam and see the target exactly for an SBRT, do you still really need a 5mm PTV since you already set the patient up and they're not moving? Or can you shrink that to 3mm, 1mm, maybe no PTV? Possibly. And that would be a huge benefit depending on the target and location. So that's one of our goals of using adaptive radiation. We talked about tumor reduction. GTV reduction as they respond to radiation, that could lead to decreased toxicity. But what really excites me is kind of novel uses of radiation that are now made possible because of adaptive radiation and things like the ethos. So one thing is can we go to higher doses now that we are treating smaller margins and smaller targets? Can we do shorter treatments? Are there more patients now eligible for SABR that weren't before because we can more safely carve around targets when we see them and plan them each day? I think the answer is yes, and these are things that we're all studying. And so kind of going back to ethos and our clinical experience, what do we use our ethos for? Well, there's daily adaptive therapy, which is kind of the most common use. And so SABR or SBRT, every, if it's 1, 3, 5 fractions, every single fraction we will adapt. There's this concept of pulsar, which is basically SABR, but separating each radiation treatment with longer gaps in time, like 1 radiation fraction or pulse every 3 weeks or 4 weeks, which I'll talk about more. Or hypofractionated treatments where we do it each time, but it's not that many treatments. Another thing that we have started doing often, but I would call it off-label use, is adaptive radiation therapy on demand. So basically, we're treating patients daily with IGRT, and then if we start noticing a shrinkage in tumor or a change in anatomy, we can request that we adapt, and then we go from IGRT to adaptive mode for the next day. We create a new plan, and then we can actually use the new adaptive plan for the subsequent IGRT plans. Which is pretty cool. Or you could choose a time frame, like once a week adaptation. That won't be the focus of this talk, but just I wanted to put that out there that there's other things we are experimenting with. Pulsar, which I want to briefly mention, is this exciting new concept from Dr. Timmerman that a lot of us at UT Southwestern are studying on protocols and trials. And this is the adaptation of SABR towards personalized medicine. And this is really where adaptive radiotherapy for SABR comes in. And so the thought process is how do we get more response adaptation? So, shrinking tumors occur, and sometimes they occur during treatment, but not always, right? So when you do conventional radiotherapy, you do little daily nudges. So in this example, this 30 gray and 10 fractions, you're giving 3 gray per fraction to this lung tumor over here. This is day 0. This is day 7. The tumor looks pretty much the exact same, right? So there's not a lot to adapt to. It hasn't changed. However, we know that tumors shrink with time. And if you had waited a day 100, this tumor is like 1/5 of the size, right? So the tumor does shrink, but it takes time. And if you're just doing conventional radiation with small dose per fraction every day, you're not going to really see that shrinkage, and then you'll be done with the radiation treatment. And so it's hard to adapt. So if you want to adapt to response, you should have waited. And so PULSAR stands for personalized ultra-fractionated stereotactic adaptive radiotherapy. So we love acronyms in radiation oncology. This challenges the need for fractionated radiation in an era of near marginless targeting of tumors, facilitated by technology. So this is a really novel concept that is turning our field upside down, right? For such a long time, we were taught that we have to do small fractions every day. And if there's any gap in treatment, that could be really bad because the tumors could grow and then the radiation wouldn't be as effective. But in the SABR era, the question is that true? If you do large doses per fraction, like in SBRT or SABR, can you, instead of giving them all at once, can you actually just wait and separate each fraction? And sorry, I have a little bit of a cold. Separate each fraction or pulse of radiation with longer periods of time. And so the key is that the doses can't be conventional doses. They have to be high SABR-like doses. So 6, 8, 10, 12 gray per fraction, high enough where it could provide local control on its own from each individual pulse. But then you can wait. Instead of giving it every day or every other day, why not wait 2 weeks or 3 weeks or 4 weeks? And so this form of split course therapy is called ultrafractionation, and this is the basis of PULSAR. And there's 3 attractions of PULSAR. So one is the most obvious, is that if you split these courses of radiation in time, it's going to be less toxic. If instead of doing a treatment every day, if you wait 3 weeks between each radiation, that's going to allow the normal tissue a lot more time to heal between each pulse of radiation. And so this PULSAR might be great for tumors in toxicity-prone locations where we wouldn't be able to do conventional SABR because we would be worried about toxicity. Maybe doing PULSAR will be safe. The other reason that is, the focus of this talk, of course, is that long intervals between pulses facilitate adaptation. So time allows for change, like tumor shrinkage. And this could be great for big tumors. Again, tumors that might be too big to treat with conventional SABR, but if you do, instead of doing 40 gray to 5 fractions, if you just do 8 gray per pulse, after 1 or 2 pulses, the tumor might shrink, and over time it might get small enough where that is safe to give that dose, and you wouldn't be able to do that with conventional SABR. The final attraction of PULSAR is that doing long intervals between pulses may actually foster adaptive immunity. And so this goes back to using radiation with immunotherapies like checkpoint inhibitors. And I have data for this. And so this study was just published last year by Dr. Timmerman and colleagues here at UT Southwestern. And this is preclinical data. And I'm not going to spend a lot of time on this, but I'll just very briefly show you that this was a mouse model experiment in a non-immunogenic mouse, so immunologically cold, where they grow this tumor in the mouse, and they give radiation, and obviously the radiation helps. And so these are the radiation curves, these are the tumor curves. But when you add PD-L1, it does nothing. And when you do radiation alone versus radiation and PD-L1, the PD-L1 has no effect. So you can tell the radiation helps, but there's no additional benefit of doing the PD-L1 either with or without radiation. And this is when the radiation is given daily or every other day. However, if you separate the radiation in time and give 1 pulse 10 gray and then wait a couple of weeks, in this case, I think it was 10 days, and then give the next pulse, now you're seeing separation in these curves. So this is the radiation only, and this is the radiation and end-to-end PD-L1 inhibitor. And so now all of a sudden, you're getting synergy between radiation and PD-L1. You're actually getting an impact of PD-L1 in an immunologically cold tumor where it was doing nothing. And the thought process is that if you do a radiation, you're affecting the tumor microenvironment, you're releasing antigens that can help immunotherapies work. But then if you give another radiation fraction the next day, you're just killing whatever immune response that you generated because obviously your immune cells are very sensitive to radiation. So if you wait 3 weeks, then you actually are giving 3 weeks for your immune system to respond and attack this tumor. And now you're getting some synergistic effect between the radiation and the immunotherapy. So, obviously these are preliminary data, but I think this is very exciting. It provides some rationale for why PULSAR, especially in combination with checkpoint inhibitors, could work better than SABR or conventional radiation with checkpoint inhibitors. And so, here's some how do we do pulsar? Well, you need to be able to deliver ablative doses. You need fast replanning in QA, and you need accurate marginless or near marginless delivery with robust image guidance. It doesn't have to be any particular machine, but we use the ethos for pulsar, and it works very well. And that's kind of been the workhorse for us. And this is kind of the process of how we do it. But I want to go to some examples now. And so this is an example of a pulsar case. So this was July 22nd last year. This large lung tumor, we gave it 10 gray, and the plan was to do 20 gray total. Instead of just giving the next 10 gray the next day or 2 days later, we decided to wait, and we waited about 4 weeks. And then on August 19th, we did a cone beam CT on ethos, and this was the tumor. The tumor shrank dramatically, right? And now, because the tumor is much smaller, using ethos and adaptive radiotherapy, we recontoured our target. If we had done the scheduled plan, meaning if we had just done this without adaptive radiotherapy, this is what we would have radiated. All of this lung tissue would have gotten treated with full dose. By adapting on ethos, we get a much more conformal plan, much less dose to nearby OARs. And it's just obvious that this is so much better than this. Here's another case of a lung pulsar. So this is 14 gray times 3. This is the time of CT sim, and this is by the third fraction. This tumor has shrunk significantly. And the tumor was abutting the kind of the top of the heart before, and so you were getting full dose in the heart when you had a PTV. In this case, now we could avoid the heart by doing ethos and adaptive radiotherapy. And you can see here, this is the schedule plan. So this is if you hadn't adapted, right, with IGRT. Look at how much full dose, 12 gray per fraction is going there. And then look at the adapted plan and how we're just carving right around the heart and still getting full dose to the tumor, which is really cool. Here's another adaptive example. This one is in the gyne area or GU area. And so this is treating the rectum. And then there's also a bony target here. And so you have one stationary target and you have one mobile target. And so often it can be hard to line them both up because this one's moving relative to this and you're doing IGRT, you might have to split the difference or come to some sort of compromise. But with adaptive radiotherapy, we can just replan based on where it is and treat both of them adequately. And so that's what this is showing you. And then I have a few more case examples. This can be used at any disease site. So here's an example of the uterus where we're using pulsar, 6 gray per pulse, and to help with bleeding, an emergent bleeding tumor in the uterus. And after 3 pulses, the bleeding actually stopped. And so we just were able to stop early and not get more radiation than needed. We've talked about some of these lung examples. Here's an example of a lymph node near the brachial plexus in the head and neck. Here's a head and neck SBRT where you had significant shrinkage in the tumor after 4 fractions and were able to adapt and treat a smaller volume. Pancreatic cancer, there's a lot of motion, both inter and intrafractional motion, and so we're able to account for that. You can see the difference between a scheduled plan with all this dose going to nearby bowel versus an adaptive plan trying to stay off of everything. And we have many protocols studying pulsar at different disease sites. So I'm the PI of a protocol looking at brain mets, but there's also gyne, rectal, bladder, non-brain mets, and upcoming protocols in GBM, head and neck, and prostate. So we're using this concept everywhere and studying it right now. But obviously we do a lot of regular SABR or SBRT where we're not doing pulsar, and the ethos and adaptive radiotherapy can be extremely beneficial in these cases too. So this is a case that I treated. This is actually PTLD, so falling under the lymphoma world. And there's only one kidney, it's transplanted right over here. And the tumor, there's only one site. And because of the kidney function, other stuff, they're not a good chemo candidate. So radiation was the best option for them. The problem is this tumor is right next to the transplanted kidney. By using ethos every day, and this kidney kind of floats around, so you never know exactly where it is. But by using ethos every day, we could account for the kidney and really radiate just around it and felt much safer, and that patient's doing very well. You hear other examples like of a large periaortic conglomerate of nodes, recurrent prostate cancer, doing a prostate SABR SIB, hypofractionated rectum, even this a palliative case where they've had prior 30 and 10 and you're really trying to stay off the prior radiation field and adapt around that. These are all cases that we've done on ethos where we found an advantage of doing adaptive radiotherapy. And so I told you I'd talk a little bit about the time. So, this was a dual target lung saber that was really difficult to set up with one ISO and a regular LINAC. And the doctor realized that this may be prone to replan. And so on average, it took 15 minutes from cone beam start to QA completion, 10 minutes to contour, 5 minutes for the plan and QA. So this whole thing only took 15 minutes. And we're able to, instead of being off here, for example, we're able to get both targets on and do saber for both of these with one ISO. And so there's a few more targets here. For the sake of time, I'm going to kind of click through some of these, and you can see, again, changes from one day to another. Here's a breast example, right? Here's the cone beam CT and a pre-plan. Here's the schedule plan. And then here's the adaptive plan. So the schedule plan is missing. There's some hot spots out here in the skin. The adaptive plan is a lot more conformal. We take away that big hot spot in the skin. And so even in breast, when we're doing PBI, the ethos can be extremely useful in this situation. Here's the example of adaptive radiation on demand with head and neck cancer shrinkage over time. And so you can see that this is the original plan on new anatomy. It's totally off, right? The tumor was here. Now the tumor is shrunk, and the normal tissue has fallen into the area that was receiving full dose. So this would be a mess. And then you're also still missing some of the target over here. But by planning and adapting, we're able to get to treat just where the target is. So I'm going to click through this real quickly. These are a few more examples kind of showing similar concepts. I want to show this. So this is a summary of everything that we've done until the end of January. So we haven't updated our February numbers yet. But we've actually, we have Halcyon, we have other machines that we use for IGRT. And so at least at UT Southwestern, we are predominantly using ethos for adaptive radiotherapy, whether it be Saber or Pulsar. And we've treated 174 patients in about 7 months with that. We've had 17 patients where we've just used it for IGRT. We have 60 patients for that concept of adaptive radiation on demand. And this is the daily ART is the majority of our patients. And you can see some examples: lung saber, 5-fraction breast saber, 5-fraction prostate saber, SIB prostate node, GI. We've done it for liver, pancreas, lymphomas, reirradiation cases. So here's just an example of the things that we're doing. Now you can see it's very diverse. All right, so I'm getting to the end. The last thing I wanted to talk about is how do we move forward and improve our ethos and improve our adaptive radiotherapy? And so one goal is to improve image quality, right? The better the image quality, the more confident we are as MDs in contouring the GTV and the targets as well as the normal tissue. So minimizing motion is important. And so, immobilization, body frame, long mass, motion management, ABC, oxygen enhanced, diffuse, or deep inspiratory breath hold, or abdominal compression. These are all techniques we use, right, to help minimize motion and improve image quality. The other things that we do is bowel prep, right? If there's a lot of gas, that quality of the image can be degraded significantly, and you can see all this, noise basically in the image. And so gas is a real problem. So bowel prep helps if we can minimize gas. We talked about motion, increasing the MAs for scanning. So the high, the more MAs you use, the better quality, and bigger patients will need it. And so here's looking at breath hold with bowel prep, breath hold alone, and breath hold with bowel prep, and looking at the difference in image quality between the two. You can see it makes a big difference. Here's looking at the difference between regular cone beam CTs and contrast enhanced cone beam CTs. For example, this was a patient I treated, actually. This was one that Dr. Wachuka treated. This is one that I treated. And without IV contrast, you can't see anything. With the contrast, now I can actually see the tumor and separate it from the bowel and the other things in this area. So the contrast made a big difference. And sometimes we use other imaging and we can fuse it, right? So we have an MRI sim. And so we can do a same-day MRI as each adaptive radiotherapy and fuse that MRI with this cone beam CT that we get at the time of treatment on ethos. And then the MRI can be very helpful in delineating our target. And so we've done that. And here's another example of doing both the dynamic contrast enhanced cone beam CT and an MRI. And this is for a liver treatment on adaptive, a liver saber treatment on adaptive radiotherapy. And here's kind of showing you how we use all these images to guide that treatment and to do the daily adaptation. Schedule plan in this example was pretty bad. The adaptive plan covers the PTV perfectly, and you can see the difference here. A couple other tips and tricks that we've learned along the way. So does an external laser help? Our therapists say yes, especially for patients in our frame, which we use for SBRT or SABR. It can help straighten patient, correct the patient positioning and rotations, take frame measurements. The location of the external laser does matter. And so our therapists want it as close to the gantry as possible in the supra-infant direction to minimize the chance that they need to push the patient on the couch. Ethos comes with the inner laser and the donut, but we like having this external laser as well. We found a way to adapt our SBRT frame so that it works with the Ethos. And so you can see the schematic. We basically turn the frame, rotate it this way, load the patient on over here, and then we'll rotate it back, which is not shown there, and then we'll use the external laser to align the patient, and then move the patient to the internal laser, and that has worked well. Last couple of slides here. So this shows timing. So one of the most common questions that we get is how much time does this take? This seems like a lot of work to do. And yes, it can be work, which is why we don't always do it every day for conventional fractionated radiation, but we really find it beneficial for any SABR or hypofractionated cases or pulsar cases. But on average, it's not that much time. So for MD time right now, our average is about 15 minutes. And most of the time is contouring, right? You can see here, this is contour modification time. The 15 minutes, only 7 minutes, the MD is actually doing things, and the other 8 minutes is kind of waiting around. And so how are we going to improve this, right? Well, one is we want to get the MD and console time to be less than 10 minutes, right? That's our goal. So one thing we can do is we've started training, and they've been really receptive to this, is training our therapists to do the contours. So to do the first stab, at least at all normals. And then when we come, we're just reviewing the normals that the therapists have already fixed, and they're getting really good at it now. And so there's less work and less things that we have to do for normal contour modification. We're still editing the GTVs and the PTVs. The other thing that we're working on is remote plan review and signing, because right now the MD has to wait. This is the extra 8 minutes is waiting for the plan and the QA and all that to happen and then approve it. If we can set up a way to do it remotely, the MD can go back to the work, do the other things, and when it's ready, they can review it remotely like we do for other stuff. Still, with this many patients and doing adaptive radiotherapy, it does affect our schedules, and our leadership has been recognizing this, and now we have time in all of our clinic schedules for planning. So this planning time is either an adaptive time where you're at the machine doing these adaptive cases, or just a regular radiation planning time. But allowing that, giving anywhere from 2 to 8 hours a week for planning time really allows us all to have the time needed to improve patient care. And so I just like to summarize everything we've talked about today. So at UT Southwestern, we actually were successful in implementing 2 ethos at the same time in a short period, in a 2-month go-live timeline. That was really aided by both the Varian-led and the UT Southwestern-led hands-on ethos art practice sessions. And we had all faculty participate in this so that everyone was kind of aware of how this workflow works. We have now every patient we treat with radiation, we will ask the question in chart rounds and among ourselves, would there be a benefit to adaptive radiation? And the simple way of thinking about it is if they fall into one of 2 categories. Do we expect that the anatomy, like the target or the AR, will change and there'd be anatomy adaptation? Or would there be a benefit from response adaptation? Is the tumor changing in size or shape over time, such as the pulsar cases? Pulsar is a novel form of SABR or SBRT that allows maximal benefit of response adaptation by increasing time between treatments or pulses. This is, things that palliatively we're doing off protocol, but most things that are non-palliative we're doing on protocol to study. With ethos, improving cone beam quality CT and training therapists to do initial contours are some of the interventions we're doing to optimize efficiency and reduce the MD at consult time. Our current time is about 15 minutes on average, and our goal is to get less than 10 minutes. And then ongoing exciting research projects at UT Southwestern include Pulsar, studying margin reduction, like PTV margin reduction to reduce toxicities, and adaptive radiotherapy on demand for those who are not SABR SBRT candidates, but instead getting conventional radiation. All of these interventions, all of these studies are ultimately done and show us how ethos and adaptive radiation can improve patient care. So with that, I'd just like to say thank you. Physicist Muhan Lin has really taken the lead here at UT Southwestern, but there's a lot of people beyond who's listed here who's made all this a possibility. So thank you very much.